So today I'm just going to run through the neurological examination, and I'll just have you watch me as I go through the examination. I had to do this at home, so there's some instruments that you typically would not use or should use better ones in hospital, but I hope the general concept is there and this is helpful for you. So to start with, the first thing you want to do is observe the patient. Observe how they're walking, so looking at their gait, their overall posture, what is their mentation like, and their behavior. So if you watch my dog, her overall behavior is quite normal. Her mentation is normal as well. If you watch her gait, she does have what's called a pacing gait, and so her thoracic limbs and her pelvic limbs on each side are going to move at the same time together at a slow pace, but as we pick up more to a trot, you'll see that it switches. This may or may not be normal for some patients. She's done it for the last 10 years of her life, and it is something that's normal for her, but something still worth noting on each patient, because again, for some patients, it might not be normal. After observing their gait, the next thing that I typically do is proprioception. So proprioception can be evaluated in a number of different ways. The way that we typically start is going to be with postural placement. Some people will call this knuckling, some people will call it proprioceptive placement, but the key is you want to be able to support a certain amount of their weight. So if you notice, I'm standing behind the patient, and I'm not just being lax about it. So be sure you're not lazy when doing this. And I'm going to be supporting a certain percentage of her weight. If I'm not supporting enough of her weight, as shown here, she'll shift her body weight to one side, and then that will be testing more of her proprioception, or her vestibular system, rather than her proprioception. The difference being, proprioception is that awareness of where our limbs are in relationship to our head, whereas vestibular system is more where is our head in relationship to gravity. When we're doing proprioception, try to avoid touching the toes, but rather try to flip the toes in such a way that the dorsal aspect of the toe will be knuckled over on itself. Again, without trying to touch it. Some dogs hate being touched so much that they could actually have proprioceptive deficits, but it's going to be hard to pick up on if you keep touching the toes. Moving up to the thoracic limbs, again you'll see that I'll be supporting a certain percentage of her weight, so that way her weight does not shift. Now you don't want to support too much weight, because then she won't try to fix her paw because there's not enough weight placed on it. Again, just demonstrating again the proprioceptive placement. Now the next part of this is hopping. Now hopping is going to evaluate not only strength, but also proprioception. The proprioceptive aspect of it is if you look at a patient and kind of draw a line down midline, the moment their paw hits midline, if not sooner, they should then correct the paw. Whenever you're doing hopping, you should always hop laterally and not medially. A patient should be able to support the majority of their weight on one limb. So if you watch, I'm lifting and she's probably putting close to 70 or 80% of her weight on that limb. If her body weight, when pushing her sideways, were to get way past midline before she corrects herself, I would be worried that the patient has proprioceptive deficit. Now, if a patient, when you're pushing them to the side, corrects their paw in the proper amount of time, but it's difficult for them, in those patients, I'm more concerned, could there actually be a weakness rather than proprioceptive deficit? So if you see with her, I'm not getting anywhere close to midline before she corrects herself. The pelvic limbs can be a little bit trickier But if you watch, I'm going to be putting a little bit of pressure on the top here, so that way she has to bear her weight, because some dogs will try to shift their weight when you're pushing them to the side. You can use the front limbs as more of a pivot in bigger dogs, so you don't have to lift up all their weight. So again, pushing down and sideways, and make sure that you have good traction when you're doing this. The next test that we'll do for proprioceptive placement is going to be extensor postural thrust. Now she's a little bit of a large girl to be doing this in, but I'll do it just to show you the example of how it's done. So I lift her up, and once her feet touch, I move her backwards. She does a very good job of showing you what normal would look like with extensor postural thrust. So both limbs should move at the same time and be fairly brisk with it. The next proprioceptive placement is going to be wheelbarrowing. Now normally with wheelbarrowing, ideally you would have someone lifting the head at one point and then letting the head go, but I'm having to do this on my own, so I didn't do it here. But you're going to lift their weight in the back half of them in their hindquarters, so that way the majority of their weight is going to be supported on the thoracic limbs. The benefit of lifting the head is if they do well when the head is lifted, but then worse once the head is down, that could be a sign of weakness because they're having to support more of their weight. Whereas if they do better when their head's down, but worse when the head is up, that could be a sign of proprioceptive deficits as they're compensating with the visual system. So here, lifting the legs and pushing her forward. You can see she's nice and even with it and doesn't have any true deficits. This is hemi-walking, and when we're doing hemi-walking, we're lifting up one side of the limbs and then pushing them sideways. Again, always going sideways and not medially. This can be helpful if there is concern about some degree of ataxia or proprioceptive deficits, but the other tests have not been helpful in finding it. Sometimes this can be very helpful with lateralized lesions, especially to the forebrain. If we're getting proprioceptive deficits elsewhere, we usually don't do this postural reaction. The next step that I typically do is the cranial nerve examination. Now my other lecture goes into much more detail as far as doing the cranial nerve exam, but here I want to show you just how to do each aspect of it. So I typically start with a menace, and I come in from the side and then from the front. Remember that the menace is a response and not a reflex, so a patient has to be of a certain age for this to be present. Typically I would cover up one eye, so that way we can assess each eye individually. Next I usually do oculocephalic, so as you move their head side to side, you should see the slow and the fast phase with each movement. And then you can do palpebral, and the palpebral reflex is going to be testing sensation. So it'll be the ophthalmic branch of cranial nerve 5 for the input, and then the facial nerve is going to be what causes the actual blink to occur. If you touch the muzzle of a dog, typically they should blink, so that's going to be checking the maxillary branch of cranial nerve 5 for sensation. The next part that I typically check is going to be with pupillary light reflex. So the first thing that I'll do, you'll notice, is I shine the light right at the bridge of the nose. This should be done in a dark setting. When you shine the light at the bridge of the nose, you should be able to see the tapetal reflection in each eye to get a best assessment as far as is there any degree of anisocoria. After checking for any anisocoria, then you can evaluate each eye. So it should be a bright light, and you shine it directly into one eye to assess the direct PLR, and then quickly to the other eye to assess the indirect PLR. After you've assessed the PLR, you should give them a break between each eye so that way the eye can dilate again. And then assess the direct in one eye, and then quickly look at the other eye to assess the indirect, and then do the swinging flashlight test to see if there's any dilation of the pupils while doing it. The next part that I usually do is checking the rest of the facial sensation. So we've assessed the medial canthus, which is the ophthalmic branch, but there's also an ophthalmic branch to the nasal planum. So usually getting an object that's blunt and doesn't have smell to it, poking them in the nose, and then also poking their ears, as that's the facial sensation, or cranial nerve 7. Last thing that I usually do is checking gag, so placing your finger at the back of the throat. And if you notice, right after doing that, one, you should feel and hear them do the gag, but they immediately lick afterwards, so you can assess the tongue movement at that point. There's no need to grab the tongue and feel it. You should be able to assess how it moves after you do the gag. The next part that we'll talk about are reflexes. So when doing reflexes, it's best to have the patient in lateral recumbency. For the thoracic limbs, you want to make sure that there's good range of motion, and you can do a quick orthopedic exam. Now, as I stated before, I don't have the proper instruments right now, so I'm going to be using hemostats instead. For the biceps reflex, you want to get that biceps under tension, and I'm doing this by pulling the limb caudally and having it flex at this 90-degree angle. My finger is near the insertion of the biceps tendon, and again I'm putting this under pressure. Where I'm looking for the reflex to actually see if it's working is in this general region, or you can actually feel the biceps tendon contract. Once it's under tension, I then hit my finger and you can see her limb contract. For the triceps reflex, it's the same scenario, getting the triceps under tension and then putting your finger near the area of the insertion, so that way you can keep it under tension and then strike your thumb. I'm using my non-dominant hand to hold the limb and then using my dominant hand to strike. If you notice, when I'm striking, it's more of a fluid type motion rather than being stiff, so the instrument is doing the majority of the work. The last reflex that we check is going to be the extensor carpi reflex, which should be in this general area, so the lateral aspect of the antebrachium. If you put a little bit of gentle pressure on that region, you can see where you should be striking the limb, and the distal portion of the carpus is what should be extending. Now again, I apologize for not having the proper instruments, because for her I could not elicit a good response to the extensor carpi. It's also important to note that these 3 reflexes that we've just gone through are not extremely reliable in every patient. The most reliable reflex is going to be the withdrawal. Now, the reason for assessing the range of motion at the beginning is when we do our withdrawal, if we know that there's going to be decreased range of motion in the joints, then we don't have to be as worried as far as how much can they flex each area and if it is or is not abnormal. We're looking for flexion of the carpus, complete flexion of the elbow, and then also looking at the shoulder. So when you do the withdrawal, putting a little bit of pinching pressure on the toe, and we're making sure that each aspect of the limb does flexion. The next part that we do is checking, is there any crossed extensor, which should not be present in a normal patient when they're in lateral recumbency. So pinching the bottom toe, and if you notice the top limb did not extend. For the pelvic limbs, the 2 reliable reflexes are going to be the patellar reflex and the withdrawal. And for the patellar reflex, I'm supporting the limb proximal to where I'm going to be striking the patellar tendon. When you strike the tendon, you should see there's going to be extension of the distal limb. The next reflex that I usually check is going to be the gastrocnemius. Gastrocnemius, best way to, at least the most reliable way that I find to test for it, is palpating for the fibellas. The fibellas, or the sesamoids of the gastrocnemius, are just caudal to the patellar ligament here, the patellar tendon. And usually once I palpate in that region, then I strike my digit, again using my non-dominant hand, and the distal portion of the limb should should flex. The next reflex that we check is going to be the cranial tibial reflex, which, similar to the extensor carpi, is on the distal aspect of the limb, and it's striking the muscle directly. And you should see flexion of the tarsus when that occurs. The last reflex that we're going to check is going to be the sciatic, and so you should be able to feel the sciatic notch. And once you have that located, either strike the digit or the sciatic notch directly. The last reflex that we check, typically, because it makes the patients upset, is going to be flexor. So again, looking for flexion of the tarsus, the stifle, but also the hip. As far as flexion of the stifle and the tarsus, that's going to be controlled by the sciatic nerve, whereas flexion of the hip is going to be the femoral nerve. So evaluate each aspect individually. I did forget to check her range of motion, so if there's any question as far as how good is the withdrawal, make sure the range of motion is normal, and then check the down leg to see if there's crossed extensor of the up leg, because again, it should not be present. Patellar, the gastroc, cranial tibial, and then the sciatic. Last thing that we usually check for while they're in lateral recumbency is going to be the perineal reflex. So rather than pinching, I usually find that just poking around the perineum gives you a good reflex or winking response. After that's done, most of the time, once we're done with the first side, we'll flip the patient on their back and evaluate for any pathologic or spontaneous nystagmus. After we're done with the reflexes, try to allow the patient to stand on their own to assess how they get up. Remember, dogs and cats should get up in the thoracic limbs first and then the pelvic limbs. Once they're standing again, we'll typically assess the cutaneous trunci. So it's just by pinching, or you can use hemostats to elicit the response. Where I'm feeling for right here are the wings of the ilium, which are usually around L5, L6, and that's where the cutaneous trunci is going to start. When we pinch, the sensation is going to be at that level. Remember, it travels cranially, and then it synapses here at around C8, T1, and it sends out projections in the lateral thoracic nerve, which causes the cutaneous trunci muscle to flex. Once you get a response, you don't have to keep working your way up. The next thing that I do is check for hyperpathia. This is done with gentle palpation initially, and then you can put more and more force. Where I'm feeling as far as where I palpate, where my two fingers are pointing, are to the spinous processes. So this is a spinous process of one vertebra and a spinous process of the other. Then I put pressure between the spinous processes, not directly on them, and just lateral to where they're at. So when checking for spinal hyperpathia, that's the area you should be feeling for, and work your way down. When we get more caudal, because the spinous processes are not as prominent, usually I palpate directly on midline, and also the wings of the ilium can interfere with where you're able to palpate. Don't forget to do tail jack. When you're doing tail jack, you don't have to get more than 180 degrees, so try not to flex the tail all the way to their back. It just has to go upright and then side to side. When we're doing the cervical region, it's palpating for the transverse processes. So we're not going dorsally, we're palpating from the side, and you should be able to feel the transverse processes. And then similar to palpating along their back, when you're palpating the cervical region, put pressure between the transverse processes to elicit hyperpathia. You can also assess range of motion, unless the patient is overtly neck guarding. A dog should be able to touch the side of their thorax, or at least come very close to it, and that would be considered normal. You can also do dorsal flexion, and in larger patients, you can do ventral flexion. If you're ever concerned about an AA lux, dorsal or ventral flexion should not be performed. You can also, while doing dorsal flexion, look for any degree of strabismus as well. So that's what I have for the NeuroExam. If you have any questions, feel free to ask, or you can watch the other video as well.